Welcome everyone to YSC's first part of our Shady Pink Elephant End of Life series. My name is Jean Rao. I'm the Associate Director of Survivorship Programs for the Young Survival Coalition, and I'm delighted and so excited that we are doing this series and that we have with us tonight Kate Adelstein from the University of Virginia. A couple of housekeeping matters. If you signed up and registered to take part in the research study that we're doing with the University of Louisville, please know that we need you to fill out the survey, which is very short, at the end of the program. It will be posted later on in the presentation. The other piece is that we want you to know that the materials will be available after the presentation is finished. It will be housed on our YouTube channel, and it will take a little while for that to happen, so please be patient. But you will be able to look at the slides again. If you are not participating in the study, we still need you to fill out the survey so we know if you learned something new or if there's more information that you'd still like to know. If you are a social worker or a nurse seeking the 1 hour of free continuing education, please do fill out the survey and then email me to get instructions to get your CEU certificate. All of this will be posted again at the end of the presentation, so please know this won't be the first time or the last that you will hear this from me. Now I'd like to introduce Kate. She graduated in 2008 from Yale University School of Nursing with a dual practice specialty in adult primary care and women's health. She worked as a nurse practitioner from 2008 to 2009 at the Dimock Community Health Center, where she provided routine OB and GYN care and spearheaded a confidential teen contraceptive clinic. She moved on to Tufts Medical Center from 2010 to 2012 as a nurse practitioner in a cancer center with a clinical focus on hematologic malignancies and palliative care. She is in the process of getting her PhD at UVA with a research focus on end-of-life care for young adults with advanced cancer and promoting well-being in that population. She is also pursuing a postmaster's certificate in psychiatric and mental health nursing and hopes to provide counseling to seriously ill patients in addition to teaching and research. She's really passionate about this topic, and you all are in for a treat tonight. So without further ado, I'm happy to introduce our presenter, Kate Adelstein.
Thank you so much. Thank you so much, Jean. I'm so excited to be here. I just wanted to say thank you to Jean and the Young Survival Coalition for inviting me. Like she said, this is one of my favorite topics to talk about, so I feel really excited to talk about palliative care and the benefits of palliative care with you guys. I also wanted to apologize. I managed to come down with a cold this morning, so I'm a little bit raspy, but maybe that will add a little intrigue to the presentation. So I just wanted to, so I guess we can just go ahead and get started. The title of my topic is, I think really, my presentation really sums up my feelings about palliative care, which is that the idea of palliative care is to live as well as possible for as long as possible. So what is palliative care? Well, the World Health Organization defines palliative care as an approach that provides quality of life, that improves quality of life for patients and their families facing problems associated with life-threatening illness through the prevention of suffering by early intervention and impeccable assessment and treatment of pain and other problems, physical, psychological, and spiritual. And I think this definition really encompasses, it's sort of long and wordy, but I think it really encompasses a lot of very important components of palliative care, including the focus on quality of life, the focus on both patients and their families, the fact that palliative care is for all life-threatening or life-limiting illness, not just cancer. In fact, palliative care is very useful in heart disease, in Alzheimer's, in lung disease, and a variety of other different problems. The whole idea is to, like I said, improve quality of life and prevent suffering. And it does say here early intervention. So even the World Health Organization recognizes that palliative care is something that we should be starting very early, essentially right after diagnosis. And we'll talk a little bit about what impeccable assessment means, and then the variety of things that we can do. Oftentimes those of us in healthcare, and I think broadly, we think of suffering as being physical pain. But in fact, suffering can be physical, existential, psychological, spiritual, and the physical suffering that people have can, of course, go beyond pain as well. So palliative care is a broad umbrella term, and it certainly encompasses a lot of important topics that we're going to talk about today. So another slide, here's my umbrella. Like I said, palliative care is an umbrella term. So just a little bit more about what is palliative care. It's basically about relieving and soothing any symptoms that may be associated with a disease or a disorder, or the treatment of that disorder. So oftentimes, especially with conditions like cancer, a variety of different cancers, the cancer can cause some discomfort, but it's really the treatment that causes most of the discomfort, with chemotherapy causing nausea and hair loss and pain and fatigue, and radiation can cause those things as well. And so it's really the treatment of the disease that causes a lot of the physical symptoms. So it's not just the symptoms from the disease that we're treating. Again, the focus is quality of life, and quality of life is a term that we throw around a lot in healthcare, and it basically means that you're able to do whatever it is that what you want to do, what brings meaning to your life, even as you're undergoing treatment for a life-limiting illness such as cancer. So palliative care also can sound really scary to people because they associate it with end of life. But in fact, palliative care can and should be provided at the same time as curative treatments. So like I said, the treatment for cancer can often cause as much suffering as the disease itself. And so while people are undergoing chemotherapy, that's the perfect time to be receiving palliative care as well, because palliative care can help people stay up and about and doing the things that they love to do and the things that bring them joy and happiness, even while they're struggling through treatment for a difficult disease. And then one of the great things that we're learning about palliative care is that especially when it's started early, just after diagnosis, palliative care can help patients recover better and faster than just the curative treatments alone. And in fact, there was a landmark study done in 2010. It was published in the New England Journal of Medicine, which is the sort of the premier medical journal in this country, sort of in the field, basically. And it looked at psychological and spiritual distress, but also survival in patients with non-small cell lung cancer when they received, so there were two groups, and one group received consultation with palliative care at the time of diagnosis and then monthly thereafter throughout their treatment. And one group received just standard treatment and did not meet with a palliative care team. And they actually found a 2-month survival gain, 2.7-month survival gain in the folks who were consulted by palliative care. So, and those people also reported higher quality of life, less emotional distress, less depression throughout the course of their treatment. And they, in fact, really did statistically significantly live longer than the other groups. So we know that palliative care is about living well, and we're learning very quickly that it is in fact about living longer as well. So a lot of people will confuse hospice care with palliative care. So I wanted to talk a little bit about what is hospice. Hospice is also something really special and close to my heart, but hospice care is a type of palliative care. So the term palliative care actually grew out of the hospice movement, which started in the 1960s in England. But hospice care is specifically for people, for patients for whom cure is no longer possible, for people who have a disease with a prognosis of less than 6 months. So hospice care really is what we call end-of-life care. So the palliative care that we provide folks who are receiving hospice is about comfort, control, and dignity at the end of their lives. And so we do a lot of similar things in terms of controlling symptoms and controlling pain and controlling things like shortness of breath and nausea. But the focus is much more about helping people transition through the end of their life, whereas with general overall palliative care, it's much more about helping people continue to live meaningful lives. So hospice care also treats the family as well as palliative care, and the focus for the family is on letting go of their loved ones, saying everything that they need to say, and then hospice will usually also include grief and bereavement services for loved ones as well after the passing of their patient. So hospice care is a wonderful service, but it's not the same as palliative care. It's only one part of palliative care. So I have this is a little bit blurry. I tried to make it sharper. But I'm not that great with PowerPoint. So I wanted to show you this Venn diagram. If you take yourself back to 8th grade math class, when they teach you about Venn diagrams, they're about these Venn diagrams sort of are a visual way of looking at things that are related to one another but are not the same. They have overlapping concepts. And so you can see here with this Venn diagram of palliative care and hospice care what things are very similar about hospice care, the focus on quality of life, emotional, physical, and spiritual support, and which things are different. So with palliative care, there's no life expectancy limit. So you can receive a diagnosis that we actually don't think, that could be life-limiting in terms of the treatment, but may in fact be very highly curable. So we expect you to be cured of this disease, and you can still be eligible and receive palliative care and benefit greatly from it. Palliative care services are generally covered under your regular medical insurance as well as Medicare, and hospice care is what we call a global benefit under Medicare. For those who aren't of Medicare eligible age, most private insurances will also cover hospice as a global benefit. And palliative care is given or is designed to be given alongside more aggressive treatments to help promote quality of life, while hospice care is about pain management and other symptom management that will allow patients to pass away peacefully and without pain and suffering. So I do like this Venn diagram because it really shows the overlapping components and the things that are different, and it's color coordinated, which I like too. So let's talk a little bit about palliative care. I'm not sure how many of you have ever been consulted by palliative care, but palliative care in most places is a team effort. In the hospital, we use the term service. So we have the oncology service, and then we'll have a palliative care service. And the palliative care team are consultants. And so nurses, family members, patients, or doctors can request a consult by the palliative care team. And then the palliative care team will come and consult with the patient. But that doesn't mean that they're just there one time. It just means that they come in and consult with the patient and develop a plan, but they'll help enact that plan. So palliative care is provided by a team of professionals. We have specially trained palliative care physicians, nurses, nurse practitioners, specially trained palliative care social workers. Oftentimes teams will include pharmacists, chaplains, physical therapists. I didn't put it on here, but also occupational therapists if that's what the patient needs, dietitians, and other professionals, including massage therapists, Reiki therapists, acupuncturists, and all of these teams. So you may not, you're not necessarily going to be in a clinic room or in a hospital bed and have 7 different people arriving in your room to consult with you about your plan. But all of these people work closely together, and so you may have a nurse a nurse practitioner or a physician visit you to talk to you about what your goals of care are, what your needs are, and then they will hook you up with social workers, pharmacists, dietitians, and anybody else who might be able to contribute to your plan of care. So I also wanted to emphasize that, in fact, you should consider yourself the captain of that team. Oftentimes we have a team of doctors caring for us when we're very ill, and the physician is the captain of that team because the physician is steering that ship. And that may be appropriate with his or her expertise in that area. But when the focus of the care is on quality of life and helping you live a meaningful life, your expertise and the expertise of your loved ones is actually the most important thing, because the whole goal of palliative care is to help you keep doing what you want to do, so you know what it is that you want to do. And so you should consider yourself the captain of that ship and the captain of that team, and remember that we're not placing a plan on you, we're not giving you a plan of action. In palliative care, it's about working together with patients and their families to come up with a plan of action. So the most important member of the palliative care team is you. So before you would meet with a palliative care team, it would be important to think about what is very important to you. So a lot of times the very first question that a palliative physician or nurse or social worker will ask a patient is, what makes your life meaningful? What are the things that you love to do? Or what are your biggest fears, or what are you most worried about when it comes to getting started with this treatment or being diagnosed with a very scary illness? And so these are some of the things that we hear very often. Patients are, and you guys are actually the expert on this more than me. People want to make sure that they are treated with dignity and respect. They want to make sure that their families feel cared for as well, and that everybody in their immediate circle knows what's going on and feels involved. And also knowing that a lot of times people have young children, or people have other folks in their lives who may also need support and care during this time. People want to continue to be part of their community. They want to continue to feel like they can enjoy their lives, like there are still good things that they can look forward to. Of course, people want to make sure that they get the treatment and the care that's the best for them, depending on what kind of cancer or other disease that they're diagnosed with. They want to make sure that they, whether the goal is complete cure, whether the goal is the longest remission possible, or whether the goal is a peaceful transition to end of life. Folks really want to make sure that they're informed about the true nature of their disease and what treatment is going to be the very best for their disorder and their lives. And I think a lot of times folks get very overwhelmed by all of the medical jargon that gets thrown around, and especially with a cancer diagnosis, things can happen very, very quickly. And patients are under the gun to make some serious life-altering decisions. And so people want to make sure that they understand exactly what's going on, that they know the truth about their situation so that they can make the best decisions possible. So these are the kinds of things that the palliative care team hears a lot when they ask these questions about what's most important. So these are the things that they're really good at building a plan of care around. But the team can, you may not be able to think of these things while you're going through all of the diagnostic testing, and all, that's a very hectic and very scary time. So the team will help with that too. So we're not giving you pre-homework before you meet with the palliative care team. They'll come, and oftentimes what's wonderful about having them be a consult team is that they're not under the gun to spend only 15 minutes with you. They can come and really talk to you and learn about you, and they can do that over time as well. So I've listed here a number of questions that are very common that you might hear from palliative care team members. How can we help you live well? What makes you happy? These kinds of things that are sort of broad and existential. What is it that gives your life meaning day to day, the things that you wouldn't want to lose? What kind of activities or experiences would you like to continue to do? Oftentimes people will say things like, I love going for my daily walk and I really don't want to lose that, and the palliative care team can work that out. Or I love listening to music, or I love having family dinners. And there are ways that we can make sure, or do our best to make sure that people can still have these experiences that they love while they're going through treatment. Another really important question, I think, is about fears and worries, because a lot of times our oncologists in particular are very gung-ho to get going on treatment at all costs, and be brave and get going with that battle. And that's a whole nother topic about war and battle metaphors. But oftentimes as we go into battle with these diseases, there are a lot of fears and worries. And very often there are lots of, the fears and worries are very common, and very often there are lots of things that we can do to address those things. And sometimes serious illness can be a great burden on people financially. People will stop working, and so especially our social workers are brilliant at helping out with those kinds of things, thinking about childcare, thinking about transportation to and from treatments, thinking about finding grants and helping with that kind of stuff. And we always like to bring in family and loved ones into these conversations, and what's important. What are your hopes and fears about your family and loved ones as they're also accompanying you through this process. And then this question, what keeps you going when life's challenges seem overwhelming? This is important that I've learned in my psychiatric mental health training, I think, to remember that we've all been through challenges before. We're all very resilient people, and we all have our own resources and reserves that we've used in the past, and it's important to be reminded of that in these situations. You've made it through challenges in the past. You can make it through this challenge using a lot of the same strategies that you've used in the past. We always like to know about spiritual or religious needs. Facing mortality is an existential experience, and so whether you're religious or not, there are a lot of different spiritual concerns that we can address in a variety of ways. So these are the sort of variety and expanse of questions that you may encounter from a palliative care consult team. And so how might that team help you? So there's a number of different things that the team can do. Once we have done that impeccable assessment, as the World Health Organization calls it, asking about fears and hopes and what brings meaning to your life and what are your spiritual concerns and what are your practical concerns, there are a variety of things that each of the team members can do. So in sort of the more traditional way, physicians and nurse practitioners can prescribe treatments to help with pain control and other uncomfortable symptoms like fatigue, nausea, shortness of breath. But medications are not the only thing that can help with these things. Acupuncture, massage therapy, physical therapy can also really help prevent or can help alleviate a lot of these symptoms. And so physicians will work together with complementary care providers and dietitians and so on and so forth to help relieve some of these symptoms for you. If you are experiencing a lot of nausea, or if you have something, for example, where you're not supposed to be taking in food by mouth, we'll work with dietitians to help make sure that you get the nutrition that you need, get the hydration that you need to help you feel the best that you can. So it's not just about prescribing pain pills. There's a lot that we can do to help relieve symptoms. The palliative care team can really help assist with weighing the pros and cons of various treatments. So one of the major things that palliative care teams do is talk through with patients what their goals of treatment are, and really help with key decision making. So I asked a good friend of mine who's a palliative nurse practitioner at the University of Virginia Health System, I said, if you were giving this webinar, what would be one thing that you would really stress? And he said, decision-making, helping with decision-making, treatment decision-making, and when to keep going with treatment and when to stop with treatment. Palliative care, the palliative care team is specially trained in that kind of care, and so that's another thing that they can do really well. And having them with you by your side from the very beginning is helpful, because then they know your course of treatment, they know you, they know your preferences, and over time they can really become your allies. The palliative team will also help coordinate care with your doctors and help you navigate what can be sometimes a very large and overwhelming healthcare system. So oftentimes it's your palliative nurse that you're going to call when you don't know quite what's going on or where you should be going or who you should be talking to, or your palliative care social worker about questions about what's going on and who you should be talking to. And that's something, nurse navigators or other types of navigators are popping up in a lot of cancer centers, and very oftentimes those people are part of the palliative care team. And then the palliative care team will really, in addition to assisting and coordinating, help guide you in making decisions and figuring out what the goals of care are. That list of questions I gave you is all about goals of care. So whether you're, it doesn't matter if your goal is to recover 100% and never look back. That is something that the palliative care team can certainly help you with. If your goal is to transition peacefully to the end of life, that's also something that the palliative care team can help you with. If your goal is to make sure that you're not bored during your hospital treatment, the palliative care folks can help with that. So as we get to know you over time, we can really help you live as well as possible. So I wanted to go through a quick case study to show you a real life sort of situation where palliative care really was able to help a young woman. This was a patient of mine. I've changed quite a few of the details because I wanted to protect her privacy, although I do have her permission to use the bones of her story. So Karen was a young woman, age 22, who was diagnosed with diffuse large B-cell lymphoma. You may know it as non-Hodgkin's lymphoma. So it's a very aggressive type of cancer of the lymphatic system. And she was facing essentially 6 months of serious treatment with heavy-duty chemotherapy and radiation to her chest area. And she would have been hospitalized. She had been hospitalized for about 2 weeks during her diagnosis period, but she didn't necessarily have to be hospitalized during her chemotherapy, which was a real relief to her. She was a senior in college, but had chosen to take a break and come home to Boston to be treated in Boston with us. Her parents were there, and they were present and supportive. She had great insurance, and so she knew she was going to be taken care of. And so you might ask, well, what was it that the palliative care team was able to do for this young woman? So palliative care was consulted very early for her at her own request, which we thought was really great. She was well educated and came in saying that she wanted to talk to the palliative care team. And so the palliative team consulted her while she was inpatient during her diagnosis process, and they found out that a couple of things were important to her. She was a soccer player in college, and she was missing her final senior year soccer season. And so two things about that were very important to her. One was that she was in great physical shape. She was really strong, a great runner, and she really did not want to lose her physical conditioning. She knew that she might not be in tip-top physical shape, but she wanted to stay as active as possible during her treatment. And she also really wanted to make it to a couple of her college team's soccer games. So the palliative care team consulted a physical therapist, and throughout her treatment, Karen was able to receive physical therapy that was directed at maintaining strength and balance and cardiovascular fitness throughout her entire treatment. And so she, in fact, did not lose very much muscle mass at all, and she was able to stay extremely active. Karen also had great worry and fear about pain and nausea. And so we were able to reassure her that there was a variety of treatments that we could use, and we became, so the oncology team, so at that time I was part of the oncology team and not the palliative care team, but the palliative care team came to us and said, this patient is very, very worried about nausea and pain. So this is something that you all need to be alert to, work with us, and we'll help you come up with a good regimen for preventing these problems. Nausea specifically was a big one for her that she was worried about. And so we were able to, we knew that that was really important to her, and we were able to really stay ahead of that for her. And so she never really experienced much nausea, and she had a good plan in place for pain as well. And then the last thing was that she was very anxious about coming to our infusion center and being the youngest person there. So we were able to make sure that she had a private room, and then we were also able to bring in, on her first day, a music therapist who came and sat with her and played music with her, and sort of was able to make that day, I think, for her a little bit less scary when she came into the infusion center and was very nervous about being there. And somebody was waiting for her with a guitar, and they sang through some of her favorite songs. And I wouldn't say she had a great time. It wasn't like the best day of her life, but I think she did have a good time. We did see a lot of smiles and laughs. So those are the kinds of things that the palliative care team can do. You know, the goal is to make an individualized, tailored plan of care for each patient based on what's important to them. So Karen is disease-free. She's been disease-free for, I believe, 4 years now, and she did graduate college. I'm not exactly sure what she's doing now, but she did end up graduating college. She's doing great. So what are the important takeaway messages? Palliative care is about managing the consequences of serious illness and its treatment. So not just treating pain, it's about managing the variety of things that can happen. Palliative care is about living well, doing the things that you love to do and the things that bring joy to your life. Palliative care is concerned with the whole person and the whole experience. So we're not just treating disease, we're treating the whole person, including the family. Palliative care can and should be provided alongside curative treatment. This is not something that only people who are transitioning to the end of life should be getting. Everybody should be getting this. And palliative care can be individualized and tailored to be whatever it is you need it to be. If you need us to make sure that you're not losing your physical condition, that's what we'll do. So what's important to you is what's important to us. So those are the important takeaway messages when it comes to learning about palliative care. So I just wanted to leave you with a quote from somebody that I believe is one of the greatest philosophers of our time, Albus Dumbledore. Happiness can be found even in the darkest of times if one only remembers to turn on the light. So I like to think of palliative care as the light in the dark times. So thank you very much. I'd be happy to take any questions.
Thank you so much, Kate. That was awesome. Please feel free to post your questions on the feed on the Facebook event page, and we will go through them for a little bit. We're going to keep this conversation open certainly till 9 if the conversation keeps going that way. I Kate, have a question for you. I'm curious, you know, when you're describing these wonderful resources and sort of seeing them in the workplace where you are, in the research that you're doing, what have you learned about how often these conversations are taking place, and if they're taking place, and what happens after the conversation?
Well, that's a really good question, actually. I think that more and more these conversations are taking place. In most major medical centers, there is a palliative care team. So if you're at a big teaching hospital, most likely there is a palliative care team. oftentimes it's the nurses or the physicians who will call the consult, but I want everybody to be aware that patients can ask for a palliative care consult. But I do think that more often than not, the palliative care team is consulted at the end of life when curative treatment is no longer an option. And while that is an appropriate time for palliative care to be consulted, it's not the only time that they can be. And in fact, people can get tremendous benefit from consulting right at diagnosis. And I don't think that is happening particularly often. I think palliative care is a scary thing for a lot of people because they associate it with end of life. Palliative care is only for people who are dying, but it's really not. And so the more education that we can get out there, I think, to let people know that palliative care is about living and about living well, even during treatment, I think the more will be, and that education is not just for patients, but for providers as well.
Thank you. I'm curious also about, you mentioned the war analogy, the battle analogy, and I think that's been in place since the 70s.
Yeah.
When Nixon was in office, and
yep.
I don't, the rock and the hard place in that is that you want people to fight.
Right.
They want to fight, and as a social worker and somebody who's been working in oncology for 11 years, what I've witnessed is it's not reluctance to not fight or have on sort of that armor, but is to, are they going to make themselves vulnerable in some way to the disease by doing something differently?
Right.
So how do you get around that?
Well, so my issue with the battle metaphor is really the idea that with a battle there are winners and losers, and so I think that people may think of palliative care as giving up, going to the other side of the battle, when in fact I think that it's really just building a fortress. It's making sure that there's a lot of reinforcement around you so that you can, it's about gathering, so to speak, gathering your army. If you want to think about yourself as the captain of the team, that's fine, and you could also think of yourself as the lieutenant in battle, or whoever the captain of the battle team is.
Right, the captain of the guard.
Yeah. So I would say, if we're going to follow that battle metaphor, I would say that the palliative care team, along with your oncology team, can be your army to fight this battle.
I want to go back to the list that on the slide that says your team can help with that too, and it's got that the various team members may ask, and you have a list of these great questions. Is this actually from some sort of assessment that is in place with those questions?
Well, this is from palliativecare.org, actually,
okay.
Which is an organization, it's the website of an organization that works to train palliative care physicians and give education to palliative care physicians about, so palliative care is a physician specialty and a nursing specialty now as well, and so it's not part of a specific assessment, but these are questions that are standardized and that everybody will be asked in a palliative care assessment.
So I hear from young women who often find YSC after they've been diagnosed, after they've done some treatment, where were you? Why didn't I know about you? And so I'm thinking about how for any cancer survivor, honestly, there's so much information that an individual is given at the beginning of that entire journey, and what would just be like some very simple nuggets of wisdom to say, be able to have this in your back pocket to ask if you know someone or you are at the beginning of your journey, to be able to ask for that kind of support, the palliative support that you're describing, even if a team is not in place.
Well, I think that having that list of questions, or making sure that you're going into it, it can be a really scary and overwhelming time. But keeping in the forefront of your mind that you deserve to live well during your treatment, and your concerns should be met, that there's no concern too small that your team shouldn't be able to meet to help you live well. That even if your physician is not a palliative care trained physician, their goal is still to help you live as well as possible for as long as possible. And so if you express your true feelings, if you express your fears, if you tell people what's important to you, usually, especially at cancer centers, there is a lot of information. There are people who know about things like the Young Survival Coalition and other things that are available for patients to help them. I mean, there's just, there's so many resources, and in most cancer centers there's a resource room. And just asking to see the resource room may be helpful. I have yet to see a cancer center that doesn't have support groups for people, and support groups, in-person support groups may not be perfect for everybody. It may not be the thing, but to just ask your physician what resources are available in your area, and then ask to speak to a social worker. I would say, social workers are a wealth of information and knowledge about these kinds of things. So.
How do you get around, sometimes I hear survivors talk about not wanting to be seen as difficult with their team for asking these types of questions, and certainly they're going to get reassurance from me, just like you've said tonight. My line is, you're the customer.
That's right.
Not the other way around. But
That's right.
I think it's not an uncommon hesitation to not want to be seen as difficult and asking for what, even if they're not sure what it is that would help.
Yeah, no, I agree with that. I mean, I always end every visit that I have with a patient by saying, do you have any questions? What can I do to help you? Is there anything else you need? And I think most doctors and nurses and social workers do the same thing. We want to know. It's very hard as a provider to try to guess what patients need. We know how to treat certain diseases, but we don't know what you're thinking and what you're feeling and what your real true needs are. And it's one of our biggest fears as care providers that we do or say the wrong thing. Mm-hmm. And so I think the more you speak up, the more you tell us what you need, the better care you're going to get, and the more relief we're going to feel. We're certainly not going to think of you as difficult. You'll make our jobs easier if you tell us what you need, because we have these resources. We are able to treat pain. We are able to treat nausea. We can alleviate some of your fears. We can help you do what it is that you want to do. That's our goal. And so, but it's hard when we don't know what your goals are. So if you tell us, we certainly won't think of you. I certainly would never think of that as a burden. I would think of it as being extremely helpful.
In working with the young adult cancer population, have you found communicating with young adults different in terms of introducing palliative care or them expressing their desires for certain things as compared to their older counterparts?
I have. I think that there really is a perception out there that palliative care is for end of life. And certainly when we have an 88-year-old patient diagnosed with a cancer versus a 30-year-old patient diagnosed with that same cancer, the goals of care are going to be different. An 88-year-old body can't withstand the same types of treatment. An 88-year-old person has lived a much longer life, and so the goal may be similar, to keep that patient living well as possible for as long as possible, but the time frame might be different. And so we all feel, I think, a real sense of urgency when it comes to young adults, because there are unmet life goals, unmet milestones. Oftentimes there are very young children involved. And so we do all feel like we have to sort of gear up and do as much as we possibly can to make sure that the patient lives as long as possible. And so I think that oftentimes patients are very hesitant to talk about palliative care, but I think in my experience clinically, bringing it up as a way, that 2010 New England Journal of Medicine study was a great boon to us, because once we really had evidence that palliative care does help you live longer, that was a door opener for us in terms of bringing it up to patients, that we want to consult the palliative doctor, because we believe that the palliative care team can help you not only live much better during this treatment and meet a lot of your needs, but in fact help you live longer which is our ultimate goal.
So has that become part of your conversation, using those results with individuals?
It absolutely has. You know, I think we're big in nursing on evidence-based practice, using the research to edit the way we talk about things and change our practice. And so, you know, what we've all known in our hearts for a long time about palliative care was finally evidenced for us in the New England Journal of Medicine. And so I often start the conversation exactly that way, saying I practice very evidence-based medicine, you know, and the research shows me that palliative care can do X, Y, and Z for you in this case. Would you be interested in talking to somebody from that team?
Okay. And I'm looking back again at these great questions because I'm fascinated by the idea that part of an assessment would include what makes you happy.
Absolutely.
And when you've talked with young adults with, you know, regardless of stage, but when they've been diagnosed and have had conversations about what makes them happy, first, what are their responses to that being part of the conversation? And then, since it's sort of spontaneous, what kind of responses do they give you?
I think it's always a surprise for them. I think it's a surprise for many people of many ages when their healthcare providers ask questions like, what makes you happy? What brings meaning to your life? I think it's usually a big surprise when a doctor or a nurse asks a patient about their spirituality as well. Oftentimes I get answers like spending time with my family, music, sports, cooking. You know, there's sort of, I would call them along the lines of simple pleasures. Certain foods, I get a lot of answers that are certain foods, ice cream,
Yeah.
for example. And those are the kinds of things day to day that bring us little moments of joy. And those are the kinds of things I think that we are best able to preserve throughout these long treatment journeys. You know, we can make it so that one example that I give in terms of the food example is that I had a patient who had terrible steroid-induced diabetes. And I said, you know, of course our goal here is to keep your blood sugar under control because, you know, we all know that out-of-control diabetes is a terrible thing and it can do long-term damage. But I also know that he loved ice cream. And so we adjusted his daily insulin doses so that he could have that ice cream, because those are the kinds of things that are really important day to day, these little things that bring us joy day in and day out. You know, there are these big moments in our lives, weddings and significant birthdays and graduations that punctuate our day-to-day lives with wonderful things. But it's really those little things, watching a sunset, feeling the sun on your face, petting your dog, taking a warm bubble bath, having that ice cream after dinner. Those are the things that really make us happy, bring us joy, and make our lives worth living day to day. And so those are the kinds of things that we focus on. So
you have these conversations and these wonderful spontaneous responses come, and then the next time you see these young adults, do you follow up with them about whether or not they did any of those things?
Oh, absolutely. Yes. So oftentimes we put plans in place, and so the idea is to make the plan with the patient so that we know that it's something that the patient can do. And so with Karen, for example, the palliative team met with, so she came in basically once a month for 6 months, but then came in between for other types of clinic visits. And so the palliative team saw her whenever she came in for her chemotherapy, but I was very much in touch with the palliative team throughout. And so when she came in for her clinic visits, I would check in on how she was doing with all of those palliative things too. And that's one of the great things about the team, is that they do coordinate with the oncology team. And so everybody knew what Karen's goals were and what her fears were, and so we all checked in. And you know, I think the fact that she was able to get that physical therapy was important, and that we stayed on top of things like pain and nausea for her. So it's that we always consulted with the palliative team before we saw her, because we knew that she was one of their patients, and so they said, make sure you ask about, make sure you find out, make sure you're checking in. So
well, it sounds very permission giving to me that,
yeah,
patients come in and are understandably laser focused on treating the cancer,
yeah,
but part of the whole person is taking care of themselves and doing the things that are normal and enjoyable to them and will help them thrive
that's right.
rather than just survive. Yeah.
Yeah.
So it sounds like you're doing really important work, and I hope to see more of it happening, not just in cancer centers. I think that cancer centers I think you're correct that most of those have palliative teams or a palliative consult at least, and not every place is like that.
That's right.
So I'm thinking about language that young adults who are in smaller locations or even rural locations, the language that they can use to ask to be referred even outside of where they're being treated.
I think key phrases that doctors will immediately pick up on are quality of life and goals of care. I think those are two key phrases that doctors will hear and know exactly what they mean. So if you say, I'm very concerned about my quality of life during treatment, or I'd like to talk about the goals of care, the goals of treatment. Most physicians, even who are not trained in palliative care or not in a major medical center, will probably jump on that and understand what that means. So if you have those two phrases in your back pocket, I think they're like keys to the castle.
Right. I think I'll wrap up with this question, which is, you are very well informed, and I've got some knowledge, and we've shared some great knowledge tonight. What kind of public education awareness would you like to see around palliative care and reaching a broader audience?
Well, what I would love to see is palliative care teams, hospice teams, oncology teams going out into the community. We see there are lots of health fairs and public health. Where you see people doing blood pressure checks, people doing blood sugar checks, even people now doing depression screenings, people doing foot checks, those kinds of things, going to church basements and going into a variety of different ways of reaching people to talk about these things. And I would love to see the hospice team and the palliative care team there as well. And I would also, I think it's really important. I know that this is an oncology-specific group, but I would also love to see the palliative care team make it known that palliative care is for all life-limiting illnesses: heart disease, lung disease, kidney disease. Across the board, palliative care can really help with a variety of different things that people of all ages are suffering from, including children. So, so I would like to see community health fairs include people from the palliative care team just doing education, going to churches, going to health fairs, going into their communities and saying, hey, we're here and we really want to help you live well. And so please ask to see us when you come visit the health center.
Really, and also just educating them about not being afraid of it happening, regardless of the severity of those life-limiting illnesses or stage of cancer, that it's really meant to partner with treatment from the get-go.
Exactly. Well said.
All right. Kate, thank you so much. This has been great, and you did a wonderful job. And a few things to everyone who has participated tonight. There is a slide up right now on our Facebook event page that states that there's a post-event survey, which I mentioned earlier. If you are a young woman who was diagnosed at age 41 or younger with breast cancer and you agreed to take part in the research study, please know that you need to fill out that survey, post-event survey, to continue to be in the research study itself. If you are seeking continuing ed for this presentation, please also fill out the post-survey study and then email me. And my email's up there as well and will be after the event. Also, if you're not either of those things but you participated tonight, YSC would be most appreciative if you filled out the survey to see how we did and how you're feeling about these topics now after hearing Kate present tonight. This page, the event page on YSC's Facebook page, will be open for 1 hour after the live event has finished, so that if you want to go back and post comments or questions, We will have those after the fact, and it will probably take a little bit for us to get all the answers to you. This session was recorded tonight and will be housed on our YouTube channel after it's been looked at and cleaned up a little bit. But we thank all of you for being with us tonight and look forward to having you with us for part 2 of the series in January. And Kate Adelstein, thank you again.
Thank you.